Hello, I'm Dr. Daniel S. Elliott. I'm a urologist surgeon at Mayo Clinic in Rochester, Minnesota. I focus in on my specialty of treating urinary incontinence in both men and women. A very devastating problem for a lot of people that can significantly compromise their quality of life. First of all, in dealing with men in urinary incontinence, frequently this is due to surgery for prostate cancer, or radiation for prostate cancer, or sometimes just treatment for blockage of their urine stream. And a man gets the old-fashioned, the roto-rooter, and urinary incontinence develops from this. This can dramatically affect and decrease the quality of life in many of these men. When we see individuals like this at Mayo, we first evaluate them with a history, find out what caused this problem, how long has it been going on, the severity of the problem, are they wearing, how many pads a day they're wearing. Now, the problem with pads is very relative, so you have to be careful, is it one pad, is it saturated, or 6 pads, and are they relatively dry. Very important also to include in, have they had radiation? Radiation damage can dramatically affect the quality of the surgery that we can offer. Like if we're going to be offering a sling surgery, sometimes the success is not quite what we'd want following radiation, so that's an important factor. Also, the impact upon their life. If this problem is only minimal, they don't really care about it, then sometimes we might recommend not doing anything. However, for the majority of men, this is, again, a devastating problem. Now, it sounds exaggerated to call it devastating, but it is. I've had a lot of men, they're afraid to go out, they don't, go out and have fun, go to ball games, whatever, because they're concerned about the leakage. Once we've taken an accurate history, the next step will be to perform a cystoscopic exam. Because as you know, following prostate surgery, the bladder neck contractures can occur, there can be pathology within the bladder. At this point in time of the cystoscopic exam, we rule out the contracture. If there's none, we fill the bladder up full and then have the patient give a cough and a Valsalva effort to determine the volume of leakage. If the leakage is minor, they might be a candidate for a sling. If it's severe, it might be a candidate for an artificial sphincter. Now, probably the most important criteria for determining a treatment option for men is the volume of leakage. And this is it's a subjective finding. It's difficult to do a 24-hour pad test. Some physicians can do it, but most in a busy practice cannot. And therefore, that's why I rely on the cystoscopic exam. Now, let's just say the first case scenario, an individual who has light leakage, like when they give a big cough and Valsalva, they only have some drips from the urethra. Those people, I feel, are probably a good candidate for the male sling. There are multiple different types of male slings out there, but all of them have their various different pros and cons. I have chosen a specific one that I like, but again, there's no one that's markedly better than the other. When a patient is a candidate for a sling, then it becomes very important to do proper counseling. The sling, there's a lot of data out there stating that the sling is magnificent, it works on everybody. My personal opinion, and a lot of data out there, says it's not quite that way. You really have to counsel the patient that this is a minimally invasive procedure. You do have roughly a 65–70% chance of being dry, roughly a 25–30% chance of improvement, and there can be about a 5% chance of being worse. That is a very discouraging thing when a patient is worse after this. They're not expecting it. There's a lot of disappointment that occurs with that. The counseling revolves around the failure rate of this and the success, but you also have to counsel the patient as far as being minimal activity after surgery. Very important, no lifting over 10 pounds for 6 weeks. That is an easy thing to say, a very difficult thing for the patient to carry through. Again, because this is a minimally invasive procedure, they feel good very soon after surgery, maybe a week or two, they feel great. Well, they feel good, but the sling is not set itself in place yet, so you have to be careful they don't go do lifting, leaning over, shoveling snow, grocery bags, these types of things that can make this sling slip. Now, even when the sling is done perfectly, everything is perfect, the results can, as I mentioned, have recurrence of the leakage or even a worsening. Usually in this type of situation, then we're forced to go, the next step is considering the artificial sphincter. Now, Artificial sphincter is a relatively common procedure we do at Mayo, roughly 100 to 200 a year. It's an invasive procedure in that there's 2 incisions that are made. I personally do incision in the perineum, roughly 6 centimeters, and then also up in the abdomen. Some individuals have been proposing doing a suprapubic approach, or what's called a penoscrotal approach. I never felt that this was a wise decision to do. I don't think you can get proximal enough on the urethra to do this procedure well. The artificial sphincter, technically, it can be demanding, especially on revisions individuals, individuals who have failed the sling surgery, or have had radiation, or multiple prior failed sphincters. It can be technically very demanding. Proper counseling needs to be done on these individuals also to make sure that they understand the limitations of the sphincter. The sphincter also requires an individual to come back after a 6-week healing period to have the sphincter activated. I feel very strongly they need to be taught appropriately how to use the sphincter so we get the most success out of it. Now, when a procedure works, whether it be the sling or the artificial sphincter, men are thrilled with it. They get back their quality of life. Some of the happiest individuals I deal with are the artificial sphincter ones who are totally incontinent. They cannot go outside, they cannot live their life, and after the procedure, they now can resume their normal activity. Keys to success with any anti-incontinence procedure for men is the volume that you do. So for a patient or for a physician selecting various different options, they have to feel comfortable doing it. You have to be able to counsel the patient correctly as far as the advantages of each surgery and the disadvantages. They have to be able to perform the surgery. There are multiple different technical aspects of each. The sling surgery, how tight you make this, the artificial sphincter, where you place the pump, where you place the cuff. Are you going to go too distal and have poor results, or go proximal? There are more risks, but the blood supply is better, the success is better long term. So for the patient and physician, they have to look at the volume that an individual does. It is important to select proper placement of the cuffs for if we're going to be doing a revision and doing what's called a tandem or a transcorporal sphincter, or a procedure we've designed here at Mayo for individuals who have had multiple revisions and erosions of doing a Surgicis wrap around the urethra that acts as a bulking agent to help reduce the risk of erosion. That is a very technically demanding surgery, but in these individuals that it works in, it can dramatically improve their quality of life. Thank you for the opportunity of speaking with you. I encourage all physicians out there to, be looking for these men who are suffering from this problem, because you have an opportunity to make their lives tremendously better.